Hi, I'm Dr. Gil Wilshire. I'm a board-certified physician, surgeon, and reproductive endocrinologist. Welcome to my series of podcasts where we discuss medical matters that matter to you. I'll be interviewing top experts in their fields, and we'll also be delving into fascinating backstories from deep within the world of medicine. So, I'm confident you'll find the information in these podcasts valuable, and they will assist you on your journey to optimum health. Hi, this is Dr. Gil Wilshire, and this is the Dr. Gil Show. This is where we talk about medical matters that matter to you. And remember, you can trust me because I'm a doctor.
Right.
Today, our guest is Dr. Ben Gerber. Welcome to the show, Ben.
Thank you.
What a pleasure it is. What a pleasure it is to have you here today. Ben is a general surgeon. He's newly on staff at Boone Hospital, where I work, and I've struck up a friendship with him, and I've really enjoyed his stories, his company, and his insight and the talents you've brought to Boone Hospital.
Well, thank you. I appreciate that.
So, Ben, when did you know you wanted to be a doctor?
Ooh, that's a good question.
Does it go back? And were you a child? Did you know way back then?
I actively rejected the idea of being a doctor for a while. So when I was in college, I was taking a lot of math. I was a math and biochemistry double major, and my faculty advisor at the time suggested I consider medicine, and I flatly was like, no way am I going to work that hard. Nuh-uh. I completely rejected the idea of medicine altogether, and I had this goal at the time of being a scientist. So I wanted to work in a laboratory, and I remember that when I think I was a junior in high school, or maybe a senior, one or the other. And it was sort of in that phase where people are like, so what do you want to do with your life? Kind of questions that are getting asked a lot. And you're like, I don't know. I read this really interesting article in National Geographic about how insulin was invented. And it has a bunch of interesting history. But then the real thing that changed everything was the biochemists who isolated the gene for human insulin and then were able to figure out a model of growing it in certain types of cell lines, which would produce the functional hormone, and it could be produced in a laboratory. Because up until that point, the hormone had to be isolated out of cadavers. And it was extremely expensive, and really very few people could get it, and most people who had diabetes would just die. And when they created this possibility of making it in a laboratory, it essentially made it available to lots of people to be able to get this medicine.
And that excited you.
And I thought that was
science.
Cool.
Yeah,
that
cool.
You could use science to like really help people, and that people who are suffering with a problem could be, through the application of your intellect and understanding of medicine or science, you could like help people. And anyway, that was really inspiring to me. So then when I was a high school kid, and then in my college years, I really wanted to do that.
And where did you go to college?
I went to Knox College. So it's a little liberal arts college in Galesburg, Illinois.
In Illinois. Okay,
yeah.
So you're undergrad, you like the science, then did you go to grad school?
So I didn't go to grad school. I did, I don't know exactly why, honestly, in retrospect. It was a really hectic year, my senior year, and I just didn't put together the details for what I wanted to do for a grad school application process. And I also wanted a little bit of experience of actually being in a laboratory full-time before I decided that was like where I was going to go. So I ended up deciding to take a job, and I worked at WashU, in laboratories at WashU.
Okay, so you're at a university, but as a
lab tech.
As a lab tech. Okay, so it's a real job.
Working as, I had benefits and a salary and all that kind of crap.
Makes sense.
And I worked for Irv Boehm for 2 years, and then I worked for Gene Nerbone for another 5 years at WashU. And 7
years at WashU.
So as a lab tech, yeah.
Right.
And eventually, as I went through all of that and did it for a number of years, it was really, I don't know, hit certain buttons for me, because most of the years I spent doing this patch clamping work, which is basically where you take neurons out of a mouse brain and you have to grow them in a culture, and then you take these extremely microscopic electrodes and touch the surface of the cell, and then you basically gain access to that cell electrically. You can measure how it behaves under, and then you drip little chemicals on it, and you do all these different stuff under a microscope and see, since these are neurons, they have action potential waveforms, and we can see what they shape like. And then in the model that we had, there were certain Gene Nerbonne had created several knockout mice where genes of specific kinds were destroyed, so they were gone. And then she was searching for ways to understand how they contributed to the waveforms of the mice.
So you're doing this very exciting basic science, and you could have done that the rest of your life.
It became clear to me that working for months and months on Figure 4 wasn't really exciting. It wasn't hitting my buttons, and wasn't going to mean I wasn't going to be the guy who was going to stay up really late and read more journal articles and apply for grants and get grant money, and then it just wasn't
the rat race of grant money. So was there a moment where you said, hey, I'd rather be a doctor?
So
a medical doctor.
One of the things that happened was as I was sort of been in Jean's lab for a number of years, she suggested I consider it. And I was kind of like, well,
maybe MD, PhD,
maybe.
She'd have you come back.
Yeah, I don't know.
High power double doctor.
We'll see. No. For specific reasons, if you're going to do MD, PhD, you have to be like a perfect student. Like those people are all like 4-point perfect, like GPA they don't take anybody who has even the slightest, inaccuracy on their credentials. So that was out of the question for me. But I did think that I wanted to do anyway. So she suggested that I consider medicine, and then I found a couple of different doctors that let me shadow them for a while. I thought it was interesting. I applied to medical school. I think I applied to like 50 medical schools.
Oh my goodness!
And I got rejected by all of them.
So first shot around.
All of them.
And so you did the Abe Lincoln. You just suited up and showed up and did it again.
I spent a year doing night school and getting more recent classes with, good grades, because it had been a number of years I'd been out of school, right?
I see. Okay. Right.
I asked for advice from the people, and the advisors at the medical schools basically told me that part of the issue was that I'd been out of school for so long.
Sure.
And then I did a lot of volunteering work with local free health clinics and stuff to sort of have credentials of being involved in medicine to some extent instead of just science. And then I reapplied to a much smaller number of schools, but I got in. And by then I was a Missouri state resident for a number of years, so I got in and went to Mizzou.
So you went to University of Missouri for medical school.
That's right.
And in medical school, did you start to like one specialty over the other? Did surgery kind of grab you somewhere?
Ooh, so this is another one of these sorts of things where when I remember vividly being so during medical school, for those who aren't aware of it, your first 2 years are very academic, where you're like in lectures almost all the time. And then your third year is your clinical rotations. And then your fourth year is sort of this sort of additional clinical work, but you're really about getting into medical school is what the fourth year is about. Getting into residency. So, it's all about polishing your GPA and your letters of recommendation and whatever else on your resume necessary so that you can be a great candidate to get a match.
Okay.
So during my first 2 years of med school, it was sort of routine, but towards the end of it, we were getting ready to sign up for our clinicals, and I vividly remember that we had an infectious disease doctor on faculty at MU, and he gave this talk. He was sort of talking about how you consider what kind of medicine you want to be in, and he was talking about how that there were two main schools of doctors. There were the doctors who do things to people, and then there were the doctors who think.
Okay.
And I was kind of like, well, I kind of figure I kind of like to think. I ought to be one of these thinking type doctors.
Right, with a bow tie. Right.
So I was completely expecting to go into my third year and plan my third year out to be, a great experience and go into internal medicine. That was my goal. I was going to go into internal medicine, and I did, all this stuff and went through, and I had position surgery as the last rotation, the second to last rotation,
the one you're not going to do.
That I'm not going to do, right? And it was the second to last rotation of the year. It was like surgery, then OB. I don't remember what all of them were in order, but I was pretty sure I wasn't going to do OB, and I was pretty sure I wasn't going to do surgery. And so those were kind of at the end of the line, and the surgery was, I mean, it was kind of crazy. It's almost a blur as a student because you wake up at like 4 a.m. You're
Not
there.
much sleep.
You're there before the surgery residents start their rounds because you have to prepare the list, and then you get all the charts ready. I mean, this was back in the days where they still had paper chart. They just started to transition to electronic medical records. So you had to like go get the charts and like bring them to this cart and then push it around with everybody, and they would sign
X-rays
stuff.
on,
They had X-rays on the computer, but we had a bunch of this stuff that we had to do.
They were on film. When I'm so old, they were on big films.
Right. So we had jobs to do, and then we were a critical part of how the team functioned. And then you were in the OR, and you would do stuff in the OR. And
did that click? What clicked for you, Ben?
Well, for me, I mean, like it was doing stuff in the OR was one of these sorts of things where like hours could go by and I wouldn't even realize that it happened.
Right.
You know, it's one of these sorts of things where you would get done with surgery and you'd be like, man, I really have to pee, you know, because it's been 5 hours.
The last thing that you're not even peeing down your leg, although you might have. Yeah.
You know,
now, had you been good with your hands up until then?
Yeah.
Did you know? So you've been good with your hands for your whole life, probably.
Maybe as an electrophysiologist, that was something that was really fundamental. You know, fine motor skills is always something that's been something that I found. And the other thing that really sort of was interesting to me about surgery was that surgery has a characteristic to it where it really makes a difference if you, in between the moderate and excellence. Like, you see what I mean? Like, there, virtually every case, if you sew it okay, you know, you'll be fine.
Right.
But then if you sew it perfectly every time, it's always better.
Yeah,
right? You know what I mean?
Yeah, and it's very satisfying.
It's very satisfying to do something that requires a certain degree of precision and to be able to do it well and have that be something that makes a difference. Yeah. You know, because if you're sewing on a button and you sew it on so that it sticks on their shirt, that's all that matters, right? It doesn't matter if the stitches are like, you know, perfect. But I feel like when you're stitching up fascia, if you're sloppy and you sort of grab the peritoneum and a bunch of fat in there too, you're far more likely that patient's going to get a hernia. Right. And that there's going to be an outcome that change as a consequence of the sloppy method.
So the precision and the excellence really suited you.
It does.
Yeah. Now I ended up I knew I wanted to be a surgeon, so I did surgery earlier in my third year. And I don't want to get into too many details, but they were tremendous assholes, these people. They were brutal. The residents were just brutalized. Then I had OBGYN the second half of the year, and I got into it. And it was like, whoa, they're gentlemen, they're polite, they're doing great surgeries and whatnot. So I ended up gravitating that direction. So it kind of found me, but I knew I was going to do some type of surgery. So you got a surgery residency at a medical school. Where was that?
So I did my internship at Vidant Medical Center. It was at the time they called themselves ECU, but they've changed names.
In what state?
In Greenville, North Carolina.
North Carolina. Was that like a rotating internship or surgery internship?
So that was a prelim year. So I didn't do very well in the match. Like my whole medical career, if you think about it, it's been like problem after problem. So anyway, you know, I didn't get into medical school my first time around, and I didn't get into surgery my first time around either. I had to scramble. It was the last year they actually did the old scramble. So this was crazy. So the scramble back in this time was when, if you didn't match, you would get this, you know, notification, like maybe it was like 3 days before match day that you didn't match. And then the day before match day, you would get a email at like 5:30 in the morning that listed this like huge PDF with like 100 pages that listed every residency training program in the country, and which ones for all different, and which ones had openings left. And then you basically,
your advisor help you too?
Well, it was the residency training program director at MU at the time. And she, you know, basically gave me this tiny little office, and it had like a phone and a computer for you to get on your email, and you just called everybody.
Yeah,
and it was like, who do you get through to first? And they wanted you to send you their application, and you had to get it. And the fax machines were all backed up because everybody's sending like, these applications are 50-page documents, right? So they're backed up, and and you're like pulling your hair out, and then they're trying to decide. So I got lucky because ECU was one of the places I had applied for, and they had ranked me, but I was not ranked high enough to actually match. So they took me on as a prelim, And I was really bummed out because as a prelim, you really have no commitment that you're going to like continue training any further beyond the first year, right? So you had essentially redo the match all over again and have, instead of 5 years of surgery residency, you're going to usually not get into a second year slot. You're going to get into a first year slot when you reapply. So you're 6 years of residency. And I'm already been in college, out of college for 7 years before I went to med school. Like I'm already an older guy.
Right.
So anyway, I got in at ECU and I really worked my butt off for those guys. And
they appreciate it.
And they appreciated it.
Yeah, so this is a rotating internship year.
Right.
Then so got you into residency for surgery.
They did. And that was a stroke. I mean, literally like the hand of God, because it was a stroke of luck. Usually when people match into surgery residency, there are very few that drop out anymore. Like back in 30 years ago, it was fairly common that people would drop out and that they would have these pyramidal shapes.
Brutal pyramid.
And nowadays, most folks who go into a surgery residency will stick it through. But when I was while I was at ECU, there was a residency program further south of there in Wilmington that had a prelim they had a categorical resident, which is when you're actually committed for 5 years, who dropped out. And they had a prelim, but she was already designated to go somewhere else. So by luck, I kind of, got through the grapevine a notification that they were interested. And I had already finished a whole application season. I mean, I interviewed at like 10 other places, spent all my, flying around the country trying to get interviews.
A lot of jet fuel.
Right. And then they offered me a job as a second year and I took it, like no doubt.
Beautiful.
And it would turn out to be a really good fit because they were a high volume clinical center. I mean, they didn't have a whole lot of, they do academic work too, but they weren't like lab workers. They were clinicians for the most part. And
you were working.
And that's what I wanted to do, was operate and see patients, and hundreds and thousands of them. I mean, I remember I estimate that I saw about 30 patients a day for 5 years for like 300 and some odd days a year for 5 years, right?
Right.
So you add that up. I mean, that's like
tens of thousands,
40,000 or something, probably patient encounters that happened in surgery. And 1,600 operations. I mean, it was great.
You had a great general surgery experience. You got to see everything.
Oh my gosh, yeah.
Now, is there anything any specialty that you said, well, maybe I'll spend a few more years doing cardiothoracic?
Sure.
Whatever specialty. There's so many.
Yeah, I mean, there's been a general trend of specialization in surgery, and I definitely thought about it and discussed it. But, I talked it over with my wife, and anyways, she was not interested in following my career around for multiple moves again.
Yeah, it gets old.
Because we'd already moved to, North Carolina and then moved to, another community and then been there for 4 years. And anyway, so she wasn't enthralled with the idea of going somewhere else for 1 or 2 years.
You have a marketable skill now, Ben. Let's
get a job and put roots down.
Let's get a job.
And I'm in the same sense as I don't really like sort of traveling. I'd like to stay in a place and sort of stay there for 20 years. And so we talked about it, and I was kind of attracted to colorectal surgery. I mean, it changed over time. As a junior resident, I was really interested in trauma because trauma has this kind of, there's this excitement to it where you're like snatching somebody from the jaws of death.
It's sexy. I know. Right? That was in my list when I was younger as well.
I mean, it's just so cool because it's so many. There's these algorithms and you can understand them and they are very effective. And, even if you don't have a whole lot of expertise, you can get the chest tube in that saves the patient's life. And, it was super exciting. And I was totally enthralled with trauma when I was a junior resident. And then, gradually as I got older, it was like, trauma always happens in the middle of the night.
Oh yeah, if you want to sleep, it's not your field.
And the exciting trauma is few and far between. Most of the trauma you don't actually get to operate on. You have to babysit patients for the orthopedic surgeons or the neurosurgeons or
Right.
Anyway. So I gradually got disillusioned with trauma and then started getting interested in minimally invasive surgery. I thought colorectal surgery was really fun. I thought I would maybe do that, but since I didn't do a residency. Didn't do a fellowship. I chose not to go into really anything.
Sure. So did you have any exciting times? This is in North Carolina you did a residency. Was that on a beach?
Yeah.
So what happens on a beach that doesn't happen here in the Midwest?
Oh, there's all kinds of stuff that'll happen on the beach. You'll see swimmers get hit by a boat, which is really exciting trauma-wise, because then you have a drowning patient, and then you get an injury, and they usually have these multiple lacerations.
These lacerations in these diagonal patterns.
And then some of those speedboats, I mean, they can really hurt people. So they can. It's amazing how bad the blunt force trauma.
A lot of people die here at Lake of the Ozarks. You'll get trauma from down there. So can you think any memorable moments during your training there on the beach?
The most exciting one was the night of shark bites. So
the night of shark bites.
Right. So
this isn't a B movie. This really happened.
It totally happened. And I mean, you could probably look it up on Google, because there was the last year of my surgery residency. I think it was the summer of 2016. There was just a lot of shark bites in the news all up and down the East Coast. I mean, it wasn't just North Carolina, but we were sort of the first ones, because there was this one night where I was on call, and I remember who my attending was too.
And you're the chief resident.
I was the chief resident, so
you're responsible.
And we took home calls. So every time something happened, you had to drive into the hospital and then like deal with it and then go back. So this one night we had, in the span of just a few hours, we had multiple patients who came in with shark bites, and one was this little girl. I mean, she was less than 10, and I mean, the story was that they were playing in the it was towards the late evening, and it was kind of getting close to sundown. They'd been playing in the sand and building sandcastles, and then they like walked into the beach to wash their like hands in the breakers, and then this shark got her, and it like took her hand off, was gone, and the skin was up to the elbow, and it was just this awful injury for a little girl. And I mean, from our end of things, as the receiving trauma team, we were kind of like, we took it to the OR, washed it, cleaned it up, made sure there was nothing bleeding, and we actually sent her to UNC's Children's Hospital to see if they could do anything to help with salvaging, because so much of the arm was degloved.
Right.
And
and the hand was gone.
I mean, it was in the belly of a shark somewhere. I mean, we have no idea where it was. And then a couple hours later, this very similar story, some older boy, he was a teenager, and he was out of state, like traveling from as a vacationer on the beach, basically. And a very similar story. And his left arm was gone up here, like
oh my goodness.
The deltoid. And the one about that I remember, because we obviously had to take him to the OR too, was that he had 3 tourniquets on his arm. So when we got to the OR and everything's all cleaned up, we take the first tourniquet off, which is one of these ones that's placed by EMS, and it has this very distinctive, it's sort of made of like nylon, and it has this crank on it that you can use to crank it down. And we took it off, and there's no bleeding. And then we took the other one off, and there's no bleeding. And underneath those 2 tourniquets is like a leather belt. And we took this leather belt off, and blood hits the wall. I mean, it was like, bam! Like, holy cow. So whoever it was on the beach that took their belt off,
saved his life.
Literally saved this young man's life. Because, I mean, some bystander seriously did a good job with that tourniquet. And, I mean, it was incredible.
Boy, you'll never see that again. So shark bite.
Yeah.
Now, was there much hunting done in North Carolina, like Missouri?
Yeah, right. So the North Carolina, Wilmington is sort of it's the coast, right? And then there's a whole lot of sort of lowlands, sort of swampy stuff around there. So there's a lot of hunting communities around there. And so there's one that's sort of an interesting story about how powerful a compound bow really is. So the story is this young boy who's probably early teens gets a compound bow and is brand new. And so he's trying it out. And one of the things he does with this is he's in his bedroom, and he shoots this thing at the target on the wall. And it goes through the target and through the wall, through the bathroom, and out the other wall into the next room over, and it hits his brother in the back of the neck.
Oh!
So his brother comes in with this huge broadhead, like, hunting arrowhead, like sticking out of the back of his neck. It's all in the meaty stuff back here.
It hadn't gone through to the spine.
It hadn't gone through the spine. Fortunately, it was not deep enough in to have hit any nerves or anything like that. It was a flesh wound, essentially. But we had to take it to the OR to get it out, because, I mean, it's all that crazy.
There are some arteries there.
And then the most exciting one, actually, was this story of a young man who was he was practicing with his target arrows, with his archery stuff. And then when he got done, he's being a good kid, and he's taken his stuff up to his bedroom to put it all away, and somehow slips and on the stairs and falls. Oh. And it's a target arrow, right? So it's shaped like a pencil, sort of a bullet tip, right?
Yeah.
And it has no flare to it at all.
And no cutting surface.
And no cutting surface. And so it entered his chest between his nipple and his breastbone.
Okay.
And it's all the way like poking out the back. Like barely under the skin in the back. Oh, so he like stands up, like, so we figured this all out after the fact, like, but because I mean, we don't really get this whole story in the trauma bay, like you kind of piece it together later. But I mean, so he stands up and walks out and calls ER because his parents aren't home, right? So he calls 911 and he's alone. He calls 911 and EMS comes out and he's standing in the yard waiting for them. Like standing in the yard, waiting for them with this arrow, impaled by an arrow that's like literally through his left chest, between his breast and his nipple bone, or his nipple.
That sounds like it's around his heart.
Right. So the EMS guys wheel him in, and they've cut the fletchings off, so that the fletching's been cut off, but they've got it just sitting here, and he's like on the gurney.
You don't want to pull that out because you could have a hole in something.
So they wheel him into the trauma bay, and he's just like talking to us, sitting up in the trauma bay, like, and we look him over, no other injuries.
So we get a chest X-ray.
We get a chest X-ray, and it's right through the cardiac silhouette.
Through his heart.
So we call the cardiothoracic surgeons in, and it's going to be a little while, right? Because they have to get these people. And I've actually, I gave a presentation on this one because it was so exciting. But so we got the cardiothoracic surgeons.
Do not pull the arrow out.
You don't pull the arrow.
If you learn anything from this podcast,
no doubt. Pull it out. And it went right through. It made 3 holes in his heart. It went through because they had to put him on pump and like open his chest and then basically pump all the blood out of his chest, out of his heart, and stop his heart from beating, and use the artificial machine to perfuse his body while they repaired everything. And it went through the right ventricle and through the atrial ventricular septum, which the atrial ventricular septum has the tricuspid valve there. Sorry. Yeah. So it went right to the side of the tricuspid valve, just barely missed the valve, so it didn't cause any valve injury, and then went out through the back wall of the atrium and through the IVC, through the back wall of the IVC into the paraspinal bone. So he had a hole in his inferior vena cava.
For folks, for people at home, IVC, that's a big ass vein. We call that big blue.
It's an evil vein. Yeah,
an evil vein, and it's because it's thin and it's hard to repair.
If it tears, it tears. Yeah.
Yeah.
So I mean, and the thing about it, the only thing that really saves him is the fact that the injury is occluded by the shaft of the arrow the whole time. So if he had been shot,
it's called tamponade.
Right.
If it had gone all the way through and out, it would have bled.
He would have bled to death. I mean, he would have totally had
rapidly.
Yeah, and he would have probably had what's called pericardial tamponade. He would have bled into the pericardium and squeezed the heart with his own bleeding until his heart couldn't beat. But in his case, I mean, it's just miraculous, right? I mean, that he missed the coronary artery. I mean, there's so many. This is high value real estate. There's all this important stuff really close to each other, right? And he missed all of the really like life threatening critical things that would have killed him. And I mean, it's just amazing. So,
and isn't it interesting how doctors and surgeons look at this very differently? Like for us, it's kind of cool, right? It's a
right. I mean,
right. And it doesn't mean that we're happy this person was injured, but well, if they're going to be injured, we might as well be able to.
I mean, this is the most incredible way to
help them.
Yeah,
right?
Sure.
It's amazing. It's a whole different worldview. So you got your general surgery training, and I think you had a job in Illinois for a little bit, and you came here to Boone. So through all of this, what has really grabbed your fancy? Because there's one thing that intrigued me about general surgery is you can operate on anything, and you've got to know human anatomy, head to toe, stem to stern, and you'd be able to operate pretty much on anything if you have to. So where have you gravitated, having this whole body to work with? What has really caught your interest?
So I think this type of surgery that I'm really most interested in is working on diaphragmatic hernias. So, the diaphragm is the muscle that separates your chest from your belly, from your abdomen, right? So, and it's this kind of dome-shaped muscle that's hooked to the ribs all the way around. And whenever you take a deep breath, the diaphragm muscle contracts and it actually becomes more flat. And that expands the volume of the chest, right? That's how we breathe. And yeah, that's how you open up your lungs. And so the diaphragm, I think it's an interesting area to work on hernias specifically because any hernias of the diaphragm don't protrude in a visible sense. All other hernias that you can sort of have are typically hernias that are going to protrude outward.
They bulge.
Right, they bulge out. But so diaphragm hernias will bulge, but they bulge into the chest. So they can be interesting, they can be extremely large in some cases, and people have no idea that they're there.
And this is the left side. Once again, translate for people. This is on the left side where your esophagus comes down, comes through your left diaphragm, a heavy diaphragm, into your stomach. And your stomach's supposed to be on this side, and your esophagus is supposed to be on this side.
Yep.
So that hole where the esophagus goes through can open up and expand, and things can puncture through it. Interesting.
And that's what they call a hiatal hernia, and it's the most common of all the diaphragm hernias. So there's about 4 different kinds of diaphragm hernias that can exist, but the hiatal hernia is the most common one.
So you see all these ads on TV for heartburn medicine. So heartburn absolutely. Must be a big problem.
Yeah, absolutely. I think I saw just a little while ago that there was one of these things where you can quantify what's the most prescribed medication or most used medication in the entire country of America.
Right.
So it's blood pressure medicine, diabetes medicine, and I think third in line are medicines for heartburn.
Antacids, proton pumps,
pepsids, and all those other things.
Yeah. So when should a person see a general surgeon or somebody like you who specializes in this? How do you know? Well, gee, it's just heartburn. I've been eating Tums for a few years. I can live with it. How does one end up coming to you?
So that's a good question. There's a lot of different opinions on how and when should you pursue surgical management for acid reflux disease. And I think that I like to slice it up a little bit apart and say that for people who have a hiatal hernia, that's a little different than just regular old acid reflux without the presence of a hiatal hernia because they have an anatomic abnormality. There's a part of their body that's shaped wrong, and it causes acid reflux.
How do they know they have a hernia?
That is almost the most common way it's diagnosed is on a EGD, a scope done by a down the throat kind of
gastroenterologist. So the person would typically go to a gastroenterologist. They do an upper GI scope.
Yep.
And a competent gastroenterologist can see this?
Exactly. Most of the time. If they're very small hiatal hernias, sometimes they're missed, but because they're just difficult to see. But once they get to be of a certain size, that's pretty straightforward, and they'll see
Even though they're in the esophagus and in the stomach, they can tell that there's a pouch there that shouldn't be?
Most often.
Okay.
Technically, the most sensitive way to the test that's going to most likely diagnose it is probably actually an X-ray swallow test called an esophagram, where you drink under X-ray video, and that's a little better even than the EGD at spotting hiatal hernia. But most patients don't get that test. More often, they're referred to a GI doctor for their reflux, and then they'll get an EGD. So.
Gotcha. So they would come to you that route. So they're not going to this person's not going to say, "Hey, I think I have a hernia," and walk in to see you.
Yeah, it's unlikely.
Now, what other diagnoses? I want to get back to that in a little bit. I want to go through the spectrum of conditions that you would see. So somebody watching this podcast would say, "Hey, I should see a surgeon for this." So let's start with skin. Is there any time that they would have something on their skin where because you may know this, it takes almost a year to see some of the best dermatologists here in Columbia.
Wow, really?
A year or more. I saw this guy. I'm not going to say his name or anything, but he said he could see me in January, and it was a year and a half January to see this guy. So, if you can't just run to a door, when would a person want to see a general surgeon for something on their skin, a lump, a bump?
Sure. I mean, in general, if there's any kind of a thing that you can feel that's in your skin or just under the skin that hurts, or causes or has become infected, you probably should see somebody about it. And especially if they become infected, they probably should be removed. Okay. And then if you have a wound that just won't heal, it just keeps bleeding or crusting and bleeding and crusting, that's also very suspicious. And you probably want to have that looked at and removed.
And go to a surgeon rather than maybe almost all these things you see your general practitioner, but very rapidly you'd want to go to a surgeon.
You want to have somebody who can take it off. And as a surgeon, we have
right.
that stuff in our office. I mean, like I've got supplies in my clinic to do a procedure under local anesthetic. So just numb it up and make a cut and pull off some little lump or bump and stitch it all up nice.
And stitch it beautifully.
Right. Absolutely.
Yeah, it's like a work of art when we do these things. I understand.
I mean, there are certain specific, like I typically avoid doing things on somebody's nose or in their around their eye because there are really careful techniques that need to be employed in those areas.
You let the plastics guys.
So I let the plastics guys get to those kind of things. There's things called Mohs surgery, for example. I'm definitely not going to do that. I'm not trained in that. But for a lump on your arm that looks weird, or if it's like a mole that really grew fast all of a sudden, or started to bleed, or it looks like it's a funny shape, it's not a circle anymore. You need to see somebody. Whether it's your surgeon or primary doc. I mean, and the thing about seeing the surgeon is, I mean, I've got clinic appointments next week. Right. And I can see you in next week, and I'm going to see you and take care of it at the same time. Right. I'm not going to string you along with multiple clinic visits and all this kind of stuff.
Fantastic. Now, another surgery general surgeons do quite a lot is the surgery on the gallbladder.
That's
and I want to tell you that
color.
You probably know this about surgical history. It was the GYN surgeons that developed laparoscopes.
Yeah, I know
when
that.
I started training, they had just evolved from tubes that had a mirror and a candle, and a light sort to see in there. And I still remember doing laparoscopy surgery
where you had to put your eye in.
Put your eye.
Oh my gosh! I've seen photos of that.
And they had these things that would actually hold it to your head, so it would save you a hand. You wouldn't have to hold it; it would hold the scope, so you could use your hands to look through it.
Wow!
So I remember them actually developing the camera, getting a camera on there and putting it on the TV.
Stand up
straight.
Wow,
just amazing. So
that's awesome.
I will in part take credit for the development of laparoscopy, and then you general surgeons found out you could start doing this in the tummy as well. And then the gallbladder evolved.
Well, there's so many things in surgery like that.
Everything. I mean, I've got little scars on my shoulders. Neurosurgeon, chest surgeon, everybody's using scopes nowadays. But the general surgeons really took to scopes. And after they figured out how to do gallbladders, they figured out they got to put on 3 staples, not 1, because these staples started popping off.
There's several things that were enhancements.
So you're young enough to have seen the fruits of these labors.
Yeah, sure.
So when you were training, you were obviously doing laparoscopy, and I want to talk about robots with you as well, which is a machine that goes on a laparoscope essentially. And you started doing gallbladder. So I assume you do a great number of gallbladders. Yeah,
I mean, it's the most common surgery performed by general surgeons in America.
That's it. No, that's number one.
Number one. And I mean, we, in my practice too, I mean, it's probably number one. I think it's probably close to, if not exactly, 100 gallbladders a year that I would do in a typical, and yeah, I mean, in that surgery, I mean, just to kind of give you, this is what I would tell a patient if I'm explaining to them how we do this, right? So
well, before you do that, how does a person living their life find out what symptoms do they have?
Sure.
Hey, gee, maybe I have a gallbladder problem, and maybe I should go to a surgeon like you.
Okay, so there's a little variability to this. So, the classic gallbladder symptoms are after you eat a meal, typically with some high volume of fat in that meal, you'll get crampy abdominal pains or nausea. Some people mistake it for heartburn. Sometimes the pain's described as a band across the upper abdomen. Sometimes it radiates around to the back or up to the right side or in the right shoulder.
The gallbladder is on the right side of the mid-abdomen here.
Right. And there's a lot of variability to this as far as where the pain is located. And it can be really difficult for people to diagnose this, personally. And the reason that is, I tell people that I think that the internal organs, the brain doesn't have a very good map for where they're at. Your brain has learned where your elbow is. Something touches my elbow. I've seen it. I know that's there.
Same is true in the pelvis.
Right.
Pelvic pain, it can go many different routes.
Right. And it's because, just like somebody might have a heart attack and have arm pain, the heart's not in the arm or the jaw, right? I mean, and people know that sometimes a person having a heart attack will complain of arm pain, but the same is true of any other organ inside of your body because your brain has never seen your heart. It doesn't really know where to put that.
Right.
So it's never seen your gallbladder. So you doesn't really know. So sometimes people will have gallbladder pains and they think they have acid reflux because they have pains after they eat. Mm-hmm. So they'll take a bunch of Tums and it doesn't work. But that's because they're not treating the right problem. They're treating acid reflux, but the acid reflux treatment doesn't work because they have a gallbladder.
Someone is having these pains or difficulties after they eat,
yeah,
antacids aren't helping. Might be gallbladder. Time to see Dr. Gerber.
Time to see somebody. And what they should probably get is an ultrasound of their gallbladder done.
Okay.
And most patients would easier to get in to see the primary doc and tell them about their symptoms. Their primary doc's going to order an ultrasound and find, oh, you've got stones or whatever.
Right,
you know?
right.
And once they find an abnormality, the thing about it is that the gallbladder can't be rehabilitated. You know, like
yeah, right. So if you see stones, does that mean it has to come out?
I would say it's probably a good idea.
Okay, once you have stones.
Once you have
How about
stones,
sludge?
it's pretty much the same thing. Sludge is just stones that are too small to like classify as an individual stone.
And when does one do what is a HIDA scan, Ben?
So a HIDA scan, I forget what the acronym really means, but it's a relatively, I like the HIDA scan because it's a super sensitive test for gallbladder function. And it's
some radioactivity or a tracer involved
there is.
in that?
So they give you an injection of this chemical that basically is visible on this radiograph machine. And that chemical is taken by your liver and transported into your bile system. So it fills your gallbladder up with this chemical so they can see it on the HIDA scan. And then they give you another stimulus that makes your gallbladder contract. Because the gallbladder is supposed to store bile, right? And that's its function. So whenever you eat food, there's bile needed to digest the food. It helps break up the fat.
To squish it
So
out.
the gallbladder squeezes to release the stored bile.
Right.
And then on the scan, they watch to see, does the gallbladder function like it should? Or is it sort of lazy? Or maybe it didn't fill up, like maybe it just couldn't fill or something. There's something abnormal about its function. Or even does it hurt like crazy when it activates? And if there's any of those things come up, we can identify the problem with the gallbladder, basically.
And it should come out.
And if there's an abnormality on a HIDA scan, you should probably have your gallbladder out.
And now that you're doing so many of them, what is the complication rate? It used to be if they went bad, I don't know if it was like 3%, 5%, you know, a staple would come off and it was lethal.
Sure.
In your hands, a very experienced, modern, minimally invasive surgeon, what would be a surgical complication rate from a gallbladder?
It's
1%?
Yeah, I would say it's probably about 1%. You know, not very, I mean, minimal risk of infection, minimal risk of bleeding. The common bile duct is the feared complication of the gallbladder removal is the accidental injury to the common bile duct, which is right next to the gallbladder. And it's supposed to be about once in 1,000.
Okay.
I've never had one in my practice, but a lot of surgical training is educating you about like the RB dragons. You know, that's the danger place. Don't go over there. That's where the gallbladder, the common duct is. You want to do these special things in order to prevent accidental injury to the common bile duct.
Now, are you doing gallbladders in surgery centers now outside of the hospital? Is it that routine?
It is. I mean, lots of gallbladder removals are done in surgery centers now. Although
Amazing.
right now we do them, you know, at Boone we do them at the hospital because Boone doesn't have a surgery center. But
Gotcha.
we do.
But there are doctors
There are
doing
lots
them in
of them
surgery
being
centers.
done. And it's perfectly safe to do so. You know, it's absolutely.
I've seen some. I've watched a number, and I've seen some pumpers. I say I'd rather be in the hospital for that one, but I'm glad that's becoming routine and is very, very safe. Now on TV, you see a lot of things about hernia meshes and all this stuff.
Oh yeah.
So, talk to me about hernias. How do you know if you have? You mentioned there's a bunch of places in your body you can have a hernia, but where's the most common place you have a hernia? The reason they check you out when you're starting sports in high school.
Sure.
Tell me about those types of hernias.
So the most common hernia is the inguinal hernia, and it's in the groin area, right? Where it's actually the most common hernia is specifically for men in the inguinal hernia in the cord where the attachments to your testicle traverse through the muscle layer of your abdominal wall. And you can actually, if you examine yourself really carefully, you'll be able to feel this area.
There's a natural tunnel where the vas enables the stuff to go in and out of your abdomen. Okay.
And that's because there's already a hole there. Like that's the place where a hernia is most likely to form.
Natural weak spot, like the esophagus.
Yes, exactly.
Okay.
And that's the most common hernia that there is in the country. And the next most common is the umbilical hernia.
So let's go back to the inguinal. So it's going to happen more often in men. It can happen in women.
Women can get them too.
Because the round ligament goes through there. There's a smaller ring. So how does the guy think? You're walking around, you're living your life. How does a guy realize that, gee, I may have a hernia?
So the slam dunk, the slam dunk that you know for sure there's a hernia is if you've got a bulge that's sort of in the area where the blood vessels that go down to your testicle are at. And then you can push on it and it goes back in again. If you have a bulge in your body anywhere that you can push on and it goes back in, that's a hernia, and that is nothing else other than a hernia.
That's called reducible in medical terms. So you can reduce it. And then sometimes you feel a little squish when it goes in. You can feel a little squish
right,
where the fluid or sometimes bowel or something is in there. So if you self-diagnose as a hernia, is that something you just make an appointment for you?
Yeah, absolutely.
And it's something you do all the time, right?
I mean, that's probably about 100 a year kind of thing. It's right there neck and neck with gallbladders.
Gallbladder. So what's the deal with mesh, Ben? Everybody's afraid of mesh. And I have a friend, my dear friend, on the East Coast, and he hunted down a Shouldice specialist.
Oh, yeah, in Canada.
Wires.
Yeah, sure.
Trained in Montreal, and he's in Long Island. I don't know the guy's name. But my friend went to him because he didn't use a mesh. He did a Shouldice. So what's up with meshes, Ben?
Oh, okay. So how much do you really want to know?
I want a 2-minute podcast synopsis. You could say, hey, they're fine. Let your surgeon make the decision for you and do the best in their judgment. Or, gee, we should avoid it completely. Or is there something in the middle?
So there is good reason why most surgeons use mesh. And I would say that it's probably considered standard of care by most surgeons across the country.
They're not bought off by the device companies.
Right.
They're not sending them to Hawaii and bribing them to do this. It's the surgeon's decision that this is in the best interest of the patient,
exactly.
right?
And it's not just like the surgeon just decides. It's that there's good data that shows that this is true. I mean, there's actually studies that follow this along quite well. And I mean, the real history of it, I think that it's brief, that's going to be of useful, is that people have been fixing hernias, doing surgery for hundreds of years, literally since the 1800s. And for a long time, the only available technique was stitching stuff. And there's a whole bunch of variations on how to stitch up a hernia with sutures, right? And the reason there's a bunch of variations is because none of them are really perfect. They all have problems. And then the key problem that seems to have plagued hernia repair surgery for most of that history has been the reoccurrence of the hernia. Okay. So, you get surgery, and then 5 years later, the hernias come back.
Comes back.
Okay. So because of that, there has been a general perception that, don't get a surgery unless you really need it, because it's so, the hernia might reoccur and the hernia is going to come back again. So that really changed dramatically when this man named Lichtenstein published his study with 1,000 patients for 5 years of follow-up and 0 reoccurrences in that time. And
what was Lichtenstein's technique? And
his technique was to use mesh. So he did open inguinal hernia repair surgery with a piece of mesh material. And, at first everybody was laying back, whatever, he's lying, that's not, nobody can do that. And, and then others learned his technique and very nearly produced the same level of quality. So I mean, the point is that when it comes in modern surgical technique, when performed properly, either laparoscopically or with open inguinal hernia repair using mesh, the chance of a hernia reoccurrence should be around 1%. For the rest of your life.
So why did mesh get such a bad name?
Well,
bad rap. What's going on?
So all this stuff happened like in the late 80s when Lichtenstein is publishing these things. So then basically, like what kind of mesh do you use, right? Lots of different kinds were tried for some time. There was polypropylene mesh has been around since the beginning. There was Gore-Tex mesh was used for a while. There was polyethylene mesh is used for a while.
And they put them in different places. Sometimes they were naked inside the wall of the abdomen, right there.
Sure.
And I saw you do a case just the other day where your mesh was underneath that first layer. It was kind of hidden from the bowels, so it wouldn't make adhesion.
That's exactly right. So, and over time, and we discovered that Gore-Tex mesh is really no longer used because it doesn't burrow in and it's prone for infection. Polyethylene mesh loses strength over time. And it will crack and break and create jagged edges, which might cut into things. So when you talk about all these different sorts of things where there are class action lawsuits, some of them are class action lawsuits for using mesh in places where it really wasn't a good idea, like for bladder slings.
Right, yeah. In my world, that was a big controversy.
Yeah, and then there was I forget what it was called, duo mesh. I forget now. But there were some kinds, Kugel mesh. There was one called Kugel mesh that was a mesh that was recalled because it had a polyethylene ring inside that would crack and could spear something. So several of these, types of meshes are specific, devices, which subsequently, as we learned after years of use, that they weren't really as good as we hoped.
So modern meshes are better, made of better materials.
Right. I mean, and not to say that polypropylene is some new thing. It's been around since the beginning, but it's the only one that's proven the test of time. Like all of the others have been essentially eliminated over the decades by identifying some sort of weaknesses with their design. And now almost all hernia repair is done with polypropylene mesh.
So in general, if a patient is going to a competent surgeon like you, and the surgeon suggests I can fix it with high likelihood of reliability, and it happens to involve a mesh, they shouldn't freak out or be too worried.
Yeah, absolutely.
That's actually the standard of care right now.
Yeah, absolutely.
Fantastic.
And mesh is,
that's great to hear.
People will occasionally have a problem with mesh, just like a person might occasionally have a problem with a knee replacement, where their knee replacement gets infected 5 years later because of, whatever. And mesh can get infected, years later. And I've seen that happen a few times. And it's terrible when it happens, but you have to take it out. Just like the person who has an infected joint replacement occasionally gets bad luck. And it just somehow their, joint replacement gets contaminated with bacteria. And then you have to remove it and then deal with the problem afterward.
Right.
But that's not necessarily because the mesh is somehow evil. It's just that whenever there's a foreign body implanted in a human, there is some slim possibility it could get contaminated with bacteria, and then that will create an infection that won't be easily treated, so it has to be removed.
Okay. Another common bowel issue where someone might see a general surgeon is the appendix.
Oh yeah, sure.
So you have the appendix is this little thing that hangs off.
Yeah, it's about the size of a pencil.
About the size of a pencil. It's called vermiform. It's the shape of a worm. And it's right in the lower quadrant here. It's very close to pelvic organs where I operate. And it's where the small bowel attaches to the large bowel.
Yep.
It may provide bacteria. It may seed digested food as it goes to the colon. And it may have a role, but pretty much is vestigial. I think everybody agrees. You don't need an appendix.
You can live a perfectly normal life.
You can live fine without an appendix. So how does one know if they've got an infected or inflamed or an appendicitis? How does somebody know?
So the history for that typically is gradually increasing abdominal pain. So this is an interesting little bit that talks about our thing earlier about pain and how pain inside the abdomen changes or is hard to locate. So most people who have appendicitis first start with periumbilical pain, sort of poorly distinctive.
Around the belly button.
Sort of around the belly button. It's sort of vaguely something hurts or aches or something is sore around my belly button. And then after some time passes, sometimes a couple days, they have specific pain located in the right lower quadrant. And what's happening here is the difference in the way the pain sensations are being activated. So the first pains are typically that the intestine itself is swollen, inflamed, and in pain. And as the inflammation progresses to produce inflammation of the adjacent peritoneum and the abdominal wall, the brain knows much more carefully where those are located.
Knows that address.
So that's where the pain gets located in the right lower quadrant more precisely. So oftentimes people with intestinal pains, it's sort of hard to locate where they are. When the gallbladder is like that, or sometimes the rest of the colon might be like that, where it's sort of something hurts kind of over here somewhere, but not really be able to tell where. But the appendicitis will usually eventually locate in the right lower quadrant. As a surgeon, almost every time I see a patient, it's because they've been to the emergency department for pain, and then they get a CAT scan, and the CAT scan is the modern, standard of care to confirm the diagnosis. If you don't have appendicitis on CAT scan, you're probably not going to need an appendectomy.
So when CAT scans have gotten so good, I know they've gotten quick.
They're so much faster than they used to be.
So much faster than they used to be. That a trained radiologist can reliably diagnose appendicitis with a CAT scan?
Absolutely.
Because I remember when I trained, it was, maybe we have some thickening of the fat or maybe some retroperineal. It was always kind of a maybe. But with modern CAT scans, the diagnosis is very with confidence. Huh?
Very, very good. Yes.
So if you see a swollen appendix,
you slay that organ.
You're gonna slay that dragon. You're gonna fix that problem, and you can do that usually with a telescope called a laparoscope nowadays.
You do it laparoscopic like 99% of the time.
Gotcha. Yeah. I take out a lot of appendices myself because it's involved with endometriosis, the appendix, for some reason, the tip of the appendix can grow almost every bizarre tumor you can imagine.
It is a little weird.
It's weird. Just the tip likes to do neuromas, carcinoids. You probably see other, and sometimes a cancer.
Yeah, absolutely. Appendiceal cancer is evil. It's a terrible cancer.
It's a bad thing.
It's it has a horrible prognosis because it's usually diagnosed late.
So the days of making what's called a McBurney incision, a little mini laparotomy down here, those are over. Now, how often do you get the appendix before it bursts?
In modern America, almost always. I mean, you will occasionally, I would say maybe 5% of the time we'll have a patient who shows up with a ruptured appendix and an abscess or something.
So have you treated many Amish? The Amish stay at home until they're almost dead because they're so tough. And you'll see delayed diagnoses in that population.
I haven't, not since I've come here yet.
We'll just wait.
Yeah.
They're tough folks. And I see women in my field of pelvic surgery who, as a tough kid, had a ruptured appendix and just curled up in the corner somewhere and lived. And then they come to me 10, 15 years later. They're unable to have babies. And I get in there, and it's just one massive. The body did what it's supposed to do. It walled it off. It scarred it down. Their feisty, strong immune system walled it off, and they lived. But it fried their fallopian tubes and their reproductive organs. I've seen this more than once. So you can welcome to the Midwest. You'll see some interesting things.
It makes me think of how, like, if you're in Africa, and you have ruptured appendicitis, it's about a 25% mortality. So that means there's 75% of people are going to survive somehow. And like, how does that happen? I mean, the body walls it off somehow and controls that infection. Eventually, stops it.
Where scar tissue is a good thing.
Yeah.
So you're going to trade shark bites for for delayed diagnoses here. Fantastic. Something I want our listeners to know is something that really fascinated me when I first heard it. This was as a medical student during my surgical residence, during my surgical rotation. And one of the residents asked me, what percentage of appendixes is improper, of these appendices that are taken out in a hospital over here, what percentage should be normal? Right? Isn't this great? And as a, you'd think, well, they should all be normal. Why are you taking out any normal appendices?
They should all be diseased, right?
They should all be diseased, right? But that's not the case. Can you explain this phenomenon
you're showing
to our listeners?
You're showing your age a little bit.
University of Michigan, 83. Yes.
All right. So this is connected to your problem about CT scans and your comment about how they used to be terrible.
Right.
And because it used to take like an hour or 2 hours to get a CAT scan because the patient would be in the CAT scanner for a long time. The images were kind of poor quality anyway.
They move around. The slices were thicker.
Right. So in the era in which CT scan was not readily available and you were relying upon laboratory tests and physical exam and history to make a diagnosis of appendicitis, it was generally accepted that around 10 or 20% of the time when you took out an appendix, it would turn out to be a normal appendix. And it would be a little worse for females than males because sometimes they would have ovary pains would fool you and you would go in and try to take out, and it would be some other diagnosis. But the concept there was that if you were not aggressive at surgically managing these complaints, that you would be missing appendicitis some of the time.
That's what I want people to understand. So, you're afraid of missing it.
Right.
And sending somebody out and say, oh, you're fine. And they go out in the parking lot and they die in the parking lot because you missed it.
So in the modern era where we have high resolution CT scans.
Fred Flintstone across the table.
It's extremely unusual to take out a normal appendix. I would say it's probably like less than 5% of the appendix I'm going to take out is going to be a normal appendix.
So just I want everybody to understand that in medicine, or especially in surgery, sometimes you take off a mole and it's just a mole.
Right. Sure.
But now it's not a cancer and you didn't miss it. Right. So there's these inherent trade-offs, and although our work is informed by science, it's not precise and exactly scientific as we do it.
And I mean, oftentimes I'll see a person who has a gastrointestinal complaints that are sort of hard to diagnose. Well, I'm nauseous sometimes, or I kind of have these pains sometimes, but then I've been trying these anti-acid medicines. They don't really help. And then, we get a HIDA scan. It's kind of on the borderline. Is it wrong or
it's not black and white.
It's not black and white.
Tests.
And you think, oh, well, normal for ejection fraction is 30%, and you were 30%, but that's the bottom edge of the normal range.
Right.
Your gallbladder wall was a little thickened, but there were no stones on the ultrasound.
Right.
Maybe they just didn't see them. Maybe they're there. I don't know. So sometimes we will offer that patient a gallbladder removal just to sort of clarify the picture, because it's so muddy right now. We're not really sure. And if we took the gallbladder out of the picture, then at least we know it's not that.
And we do that with pelvic pain. We'll take if a woman has bad endometriosis, we'll take the appendix. 25% of the time it has an endometriosis as well, but we take it out. So in the future, if you have severe pain, we know it's not an appendicitis.
Right. Yeah. So
those are the big, the common things that a person would see a general surgeon for. So take me through, I already told you that we GYNs developed laparoscopy in the beginning, but you all, the general surgeons, have taken it and run with it and have now added on a new feature called a robot.
So I would love to take credit for that, but it's not actually the general surgeons who are responsible for this. So interestingly, little history of the
urologist.
Almost.
Talk to me.
So the story is, if you really talk to the people at Intuitive that know the history, Intuitive got off the ground starting with cardiothoracic surgery.
That's the company that makes the Da Vinci robot.
That makes the Da Vinci robot. So I should have clarified that, but they developed this. So what the Da Vinci robot is essentially, for our listeners, is this. It's this machine that has a bunch of specific enhancements onto it, which allow it to sort of be the next generation of laparoscopy surgery. Okay, and
so it's still a telescope in the belly. It's still small holes, but it has these 3 or 4 arms.
Right. So there's several features. I kind of described them. I mean, one is that the camera it uses is substantially better than the traditional camera for regular laparoscopy. It has a binocular view. So there's 2 cameras in there. And when the surgeon uses the console, you sort of sit your head into this. So you have a depth perception, because with a 1 camera view, you will have a limited ability for depth perception.
Yeah, that's my word.
And the reason that that's really important is when it comes to things like sewing and threading needles, that small difference in depth perception becomes really much different with respect to how long it is and how easy it is to accomplish those little tasks like threading a needle or sewing. And then the other thing that the camera does is it actually magnifies the view. So it's like working with a microscope. I mean, everything is 3 times larger than it is in life. And then associated with that, the instruments that go in have additional range of motion. So your standard laparoscopic instruments can pinch and they can rotate, but they sort of wave around. And it reminds me of like the arms on that like robot from Lost in Space. With danger, Will Robinson.
Yeah, right. We call them sticks.
Right.
I operate with sticks. They're long black sticks. They have things on the very
end. They pinch and they can wave around.
But so once again, I want people to understand that once you dock this robot.
We attach
the robot. You put in the telescopes. You've actually done the surgery. You've actually done some actual hands-on surgery.
Right, we've attached everything.
You then sit over here in something called a console.
And the console allows me to control this. Essentially, it's a little mechanical hand. It has almost the same range of motion as what I can do with my hand.
So your wrists can do this, and that's translated to the wrists
inside
the body.
Except that it's like, it's this big, right? So instead of having a hole for my hand to fit in, it's a little hole for a little mechanical hand to fit in that I get to control. And it allows me to sew, and since it's so tiny, it also allows, the other thing that this thing does is for surgeons as we grow older, everybody has a certain amount of what's called physiologic tremor. So if you hold like a yardstick and you try to hold it really straight, it'll wiggle in the air. The robot cancels your physiologic tremor. And it will. It also has a scaled movement. So if I move my fingers 3 inches, the instrument inside will move some fraction of that. So it allows me this very precise movements. And I have all the same range of motions that my real hands do, right? So then I can do things where I can like hold my elbow up like this and box out something that's in my field of view. And I can still sew right here. So it allows me to do all kinds of extra things with my hands and arms. And there's a tool that allows me to use a third arm that I can rotate back and forth as to which arm I want to use there. And so anyway, there's all of these enhancements together essentially create this really useful tool for doing things that are especially in narrow little places. So when the company that created this, Intuitive Surgical, first got started, they got started working with cardiothoracic surgery. So they were doing heart valves with these tiny little holes and working inside the pericardium. And their company, dealt with a lot of the engineering problems early on working with cardiothoracic surgery. But their surgical volumes were never very high, and they were sort of dying as a company. So urology saved Intuitive from death because some guy in Europe somewhere, I forget, I think it was in Germany, did the first robotic prostatectomy. And the thing about robotic prostatectomy is that, as a prostate surgery, it's a very small little place to get to. In the male pelvis is narrow with bone all around, and it's very far in. So laparoscopic instruments are very hard to use down here. It's very hard to get, if you want to sew laparoscopically, you have to get your hands out at about 30 to 45 degree angle in order to sew. So once you start getting your fingers really close in, it's extremely difficult to get the loops necessary to sew. So sewing the ureter back together again for a prostatectomy laparoscopically was infamously difficult, and very few people had the skill necessary to do it. But with the robot, where you've got these little tiny hands and extra range of motion,
and you can place that stitch 90 degrees, perfectly square to the radius.
Exactly. Yeah. You could do very good quality work. And I mean, I guess the first robotic prostatectomy took like 9 hours or something. I mean, they were just making it up as they went along, right? Because they'd never done this before. And after urology sort of saved the robot, general surgery was one of the next ones that sort of came on board. And the thing about general surgery that was a bit of a challenge was that at the time, the robot had fairly limited range of motion in the sense that once you positioned it, you could only operate in a zone that was about this big.
Okay.
Because it couldn't swing very far out of the side to side. Like the field of surgery it could use to perform its work was fairly limited. And then as the robot company advanced, they added on new generations of their technology so that it increased range of motion, and then it became possible for surgeons to do things like hernias, which are bigger sometimes, and for us to do things like colon surgeries, which usually require a larger field because you have to remove a big section and you have to loosen up an area to bring it down. So colorectal surgery was one of the next ones that really got on board with doing, when the newer generations of robot came into existence, colorectal surgery got on board because they could do their surgeries. And what it allowed in the best series showed that for patients who had laparoscopic surgery, even with highly skilled laparoscopic centers, about 10 or 15% of those surgeries would convert to open surgery because there was something particularly difficult about it. It was maybe really inflamed, or the tumor was invaded somewhere, or the patient was really heavy, or something where they couldn't get it done safely laparoscopically. They'd go open.
It's called converting
to an open surgery.
An open case.
So, and the key thing about that is when you go open, then the patient has a much bigger wound. There's risk profile for wound infection or for hernia or for all kinds of complications gets worse with the larger wound. So the benefits of minimally invasive surgery are enjoyed by more patients with robotics because at the high volume robotic colorectal centers, their conversion rate to open is like less than 5%. So then far more patients get to enjoy the benefits of minimally invasive surgery, essentially. And even if their tumor is bigger or their disease is more inflamed or whatever. And that's kind of where robots really sort of shown a delta of quality is in colorectal surgery.
So it's not just fancy. It's like in my field also lasers were really big. Oh, we can do it with a laser. And everybody wanted to have a laser. And in the vast majority of cases, it added no benefit. It added a cost. It was a hassle factor. And it really added nothing other than for fancy marketing.
Right.
So in your training, you got trained in laparoscopy and you had robot training
I had some.
in your residency.
A little bit, yeah.
So clearly you took to it.
Yes, I did.
No, I've sat down with robots at shows and whatnot. I bet you I could be real good at it.
Probably.
But I just don't have time for it. What I do, I'm doing with the sticks. But you got the opportunity to train as a younger man and have the robot at your access. And now you were able to treat these hernias. This is something if you go on the internet, Ben has some videos through Boone Hospital where you talk about, rightfully talk about, what do you like? What is your passion? And I guess the thing that you have the most experience with are these hiatal hernias,
Absolutely,
or these
yes.
hernias around the stomach and the esophagus, and you can approach these now with the robot as well. Is that
Yeah.
right?
Absolutely. And it's
How's
changed.
the robot changed this
It's
field?
huge. I mean, because if you go back about not even maybe 10 years or so, I mean, typically these patients, laparoscopic surgery was available for this, but for particularly large hernias, it was difficult, very difficult, and kind of dangerous in certain cases, because these hernias, when they protrude through the diaphragm into the chest is sort of, it's a dangerous place. There's the heart in there. There's the lung in there.
People don't realize that esophageal surgery is frequently done by the cardiothoracic guys.
Absolutely.
Gals.
It is.
Yeah.
Oftentimes, not always, but a lot of times they're done by cardiothoracic or thoracic. And, the heart is, you don't want to get into bleeding with the heart. Okay.
I'm with you on that one.
Right. And then, I mean, also this again, it's one of these places that, like we talked about earlier, it's kind of high value real estate, because the hiatus has essentially directly behind the esophagus, as it traverses through the diaphragm, is the aorta. And then just like an inch or two below the diaphragm, and sometimes in the muscles of the diaphragm, is what's called the celiac axis. So it's this big blood vessel that feeds all of the front of the gastrointestinal tract. So the small bowel, the liver, the pancreas, the spleen, the stomach, all receive their blood flow from this main nexus of blood vessels that comes out of the aorta just below the diaphragm. So, if you're kind of not careful enough, you could easily cause accidental injury to these really important structures nearby. And there's the most commonly injured structure in a hiatal hernia surgery is the vagus nerve, which is, there's two of them, and they are attached to this. They carry along the edge of the esophagus and go to provide nerve supply to the stomach and all the intestines.
Right.
And especially in the context of very large hiatal hernias, their position is sometimes pushed in different weird directions, and they're not located where they should be. So the visualization of the camera with the magnified view and the dexterity of the robotic hands allows me to be able to far more reliably locate and preserve those structures than what would be available with standard laparoscopy. So, I can... And the other thing is that I've done enough of them with really great, outcomes. I basically do this as an outpatient now. I mean, people don't even stay in the hospital. They go home, and it used to be 3 days in the hospital, right?
Wow.
So, even just last week, I think I had 3 patients last Monday, and 2 of them were ladies over the age of 80, and they went home.
Wow.
Yeah.
That's tremendous, Ben. Are there any other surgeries you do with the robot that have been, that have benefited in such a dramatic way? Do hernias also do you do with the robot? Or?
I do. I sort of pick and choose which patients are going to really benefit from the robot.
I saw you doing one the other week where it was just a laparoscope, and you seemed to be doing just fine.
Yeah. So, and it's a matter of, one of the things is that I don't have access to the robot whenever I want it. So I can't just choose to do it all the time. So if I have a patient who needs a surgery on a timeline that's not going to work for access to the robot, then we're going to have to use whatever techniques we have available for that.
Sure.
But in general, I think that the robot really is of benefit because it allows a couple of different things for laparoscopic repair of hernia. So this kind of gets a little bit into the details of how is a hernia repaired. So, a hernia is a hole with stuff protruding through, right?
Okay.
So when you're going to repair a hernia, the first thing you need to do is pull the stuff back in that belongs inside. Okay. And then you can really carefully see the hole. And for standard laparoscopic approach, it's very difficult to actually close the hole because getting the angles of stitching through and then, putting sutures in and pulling and yanking and against the insufflation holds the, when you're filling it fights you.
We use let me explain this. We use pressurized gas, always carbon dioxide, to open the abdomen.
Right.
That gives us room to work.
So you're not instruments.
So
don't
you're
poke
making your hernia work.
So it essentially
makes
right.
it out. Yeah.
So and if with typical straight stick instruments, it's possible. I mean, some people can do it, but it's not easy. And then you also there's a hole, so the muscle layer has to be pulled more than it naturally its elasticity would allow. So it takes a lot of force to pull these muscles closed and to close the hole. So there's all these guidelines about how to do good quality laparoscopic hernia repair where you don't close the hole, but you have at least a certain amount of overlay onto muscle tissue. So that the mesh has to be bigger than the hole. So if the hole is like 2 inches in diameter, you have to have a mesh that's got at least 3 inches of overlap all around. And then you tack the bejesus out of it so it stays in position and it doesn't slip. Okay, and so that's the typical laparoscopic approach, okay, for a hernia repair. Now with the robot, because I have more, the instruments are a little stronger. It's also because the instruments move in other ways, it allows me to sew the defect of the muscle layer closed before I put the patch up. So, I mean, this sort of, I think of it as being this kind of thing where, if you had like a seam in your shirt that was ripped, and you were going to fix that by ironing on a patch, wouldn't it work better if you sewed the seam first and then ironed the patch on?
Yeah.
Wouldn't it just be a better quality closure? Right? And that's what the robot allows you to do, is to actually sew the hole closed and then also place the patch on over the top of it, actually underneath on the inside. That provides, in my opinion, a better quality. And I feel like it also has this side effect of having less pain for the patients afterward. And I think the pain issue revolves around sort of this biomechanics of how this works. So if you've got a hole,
right,
and there's a patch on it, every time you sneeze, the patch tries to bunch up through the hole, right? So all the little tacks are pulled sideways. Every time you cough, every time you sneeze, every time you bend over to tie your shoes, the tacks are being pulled a little bit to the side because the mesh is trying to bunch up out the hole. So if you close the hole, that doesn't happen. And the patients, I think they suffer less pain as a consequence. And it just, to me, it makes sense. It's biomechanics of how does the thing close and fit? How do the pieces fit together? And that's one of those things where, so for most instances where I've got a hernia of the abdominal wall that's not going to be a slam dunk, easy little cut in the front, because if it's a tiny umbilical hernia, it's usually very straightforward to just put in a mesh patch underneath and close over. But if it's maybe a reoccurrence, or it's a patient who has a big defect, or a person who might have a lot of high risk for wound infection for some reason, maybe diabetic or a smoker or something like this, then oftentimes I'll do those with the robot because I can avoid some of those other risks and provide a better quality repair than what I could do laparoscopically.
That's tremendous. It's always great to see the various fields of medicine all advancing. And in future podcasts, we're going to talk about many different fields of medicine and the recent advances, which are just so exciting. Now, is there anything in the field of general surgery that I haven't really covered that you'd like to talk about today? Anything new and exciting, or a new thing that you're doing, or
Sure.
Any kind of news? Is there something that here we are in the end of 2022?
Yeah, I mean, there's one of the things that I'm doing right now is we kind of talked a little bit about this work of hiatal hernia repair and this sort of stuff a little bit ago. So there's been a long history of how do you surgically manage acid reflux disease and how do you fix hiatal hernias. For a very long time, the sort of standard of care was this thing called the Nissen fundoplication, right, which is a surgery that's been around since the 60s. And it entails a procedure where you take a part of the stomach called the fundus and you sort of loosen it up so that it's floppy, and then you use the muscle of the stomach to stitch it around the esophagus.
So you just wrap it around the esophagus, take the upper part, wrap it around,
exactly,
tighten it up.
And that's supposed to basically use all this extra muscle tissue to sort of bolster the muscle function of the lower esophagus, right? So that's the concept of how it functions. And it's been around a very long time. And there are a couple of key disadvantages associated with that. One is that it's typically too good. Most people can't get anything to go up anymore. So people can't burp or vomit anymore. And it works really good. No more acid reflux, right? So no more acid coming up your throat. But you kind of get a little bloaty or a little gassy as a consequence because they can't get any burps out.
Burp.
And the other thing is that if you follow patients for a really long time, if they have a hiatal hernia and they get one of these techniques applied, they have a relatively high risk of reoccurrence, just like we had previously talked about with like inguinal hernia surgery and the enhancement that mesh provided to reduce the chance of hernia recurrence.
Okay.
There has been this issue for acid reflux surgeries, that there's a relatively high rate of hernia reoccurrence after surgery and these other side effects with bloating and stuff. So people for a number of years have been trying to come up with variations and innovate new techniques to try and create new things that might be better than the Nissen.
Okay.
And one of the things that's kind of been around now for some time, I think they finally got FDA approval in 2007. So they did their first 5-year follow-up in 2012. So they've been on the market for more than 10 years now. It's this device called LINX. So LINX is essentially it's a little necklace of magnetic beads where each magnet kind of aims at the next one around the circle.
Huh.
And its intent is that it sort of squeezes the esophagus a little bit and helps bolster the esophagus instead of using the stomach wrap method. Okay.
Huh.
And the key, the magnetic attraction is supposed to be pretty wimpy, so that when you swallow, they push open and then all the food can come down, but the normal digestive movements of the stomach are not supposed to be potent enough to let acid come up the wrong way. While
Just right.
it's supposed to be somewhere in between. Exactly, right? And that's the idea. And the guys who built this thing, designed it to be last a lifetime, essentially, made out of titanium and all this kind of fancy stuff. It has little neodymium magnets in there, and as far as acid reflux control has been shown, it's pretty effective. It does about as good a job, it's as any of the other techniques. Long-term, they actually have long-term follow-up studies now with more than 10 years of follow-up showing that it continues to work for a long time. And I think this may be new. As far as the new big thing on the horizon, it's been poor uptake with insurance companies. It's an implant. Implants are expensive.
Right. Insurance doesn't want to pay for anything.
Yeah. And there's lots of reasons for that. And they've also not been able to do the randomized controlled trial where half the patients got the traditional surgery and half the patients got the implant. Because, seriously, who's going to sign up for that trial?
Right.
So they haven't been able to demonstrate superiority over the traditional surgery. Now, I think that the company's starting to work in the next direction, because where they probably have demonstrated superiority is in reducing the likelihood of reoccurrence long term. Because there have been a number of studies done now that have followed patients long term, and they found that the chance of the hiatal hernia reoccurring, if you have a hiatal hernia surgery and this device used, so the patient gets a hiatal hernia in a device rather than a hiatal hernia in a wrap, their likelihood of reoccurrence is somewhere around 5%. Whereas the traditional wrap patients, depending on which study you reference, it's 25, 30, 50%. So that's a substantial improvement in quality.
And you should be able to show that difference with a moderately sized study.
Absolutely. So that's in the works, apparently, but that's probably where I think the next thing will happen as far as acid reflux surgery is concerned.
Very interesting. That's nice to know. And you can tell that I didn't have you prepare for anything, so I'm gonna hit you with another question out of the blue. I know you said you don't do much thyroid surgery, but I have perceived that there's been a change, and I see a lot of thyroid because thyroid's a hormone, and hormones affect fertility, and I'm a reproductive endocrinologist, so I deal with a lot of thyroid. And I've seen a change in practice pattern with thyroid nodules. It's not uncommon to feel a little nodule in a thyroid. It's always a woman in my case. But she's doing great. All her labs are normal, but there's this little nodule. And I've seen over the years that we used to send them to a doctor, and they'd put needles in there and try to biopsy it and do all this stuff, and ultrasounds and radioactive scans and all that kind of stuff. But I'm seeing that there's much less, people seem more comfortable just observing them over time or whatnot. Can you tell me what's going on with thyroid nodules? Because I think that still falls in general surgery, right?
I mean, it's one of those sorts of things you get trained on in general surgery, and we're required to have a certain number of thyroid cases as part of our graduation, that kind of stuff. So I did learn a whole lot about thyroid while I was in training, and I haven't kept up on a lot of it. So I'm probably a few years behind on whatever the most recent guidelines are. But my understanding is that there are ultrasound findings which are used to risk stratify a thyroid nodule. And then any thyroid nodules that meet certain guidelines based on their size and what they look like under ultrasound, when they meet certain criterion, then they will be biopsied. And then the biopsy will guide whether or not that's a malignant nodule or a benign nodule. Okay. So, once if they're changing over time, or if there are these other abnormalities with respect to how they look like, or size criterion, and if they're found to have anything, like if there's other nearby enlarged lymph nodes, for example, those are always biopsied. That suggests metastasis into a lymph node. So there's several specific findings on ultrasound which would lead towards biopsy. And then if any malignancy is found on biopsy, then it goes to surgery for removal. And and otherwise, it's not typically recommended for surgery in a sort of prophylactic sense.
So as ultrasound has gotten better, like CAT scans have gotten better, that's the change in management I'm seeing here.
And a lot less people are getting thyroidectomies probably than what there used to be, because we're sort of discovering that you can, because thyroid cancer overall has a pretty good prognosis compared to some other kinds of cancer. So, waiting a few months for a follow-up ultrasound isn't going to substantially impair the outcome for that patient, right? Their prognosis isn't going to be wounded by having got a repeat ultrasound in a few months. I think we're doing less thyroidectomies because we're doing more surveillance of lesions that are not cancer.
That makes a lot of sense. Well, thank you, Ben.
Thank you.
What a pleasure having you, Ben.
It's a pleasure.
Have a great day. Thank you.
You too.